Factitious disorder represents one of the most perplexing and challenging conditions in modern psychiatry, characterized by an individual's deliberate fabrication or induction of physical or psychological symptoms without any apparent external motivation. Unlike malingering, where someone feigns illness for tangible benefits such as financial compensation or avoiding responsibilities, factitious disorder stems from an internal psychological need to assume the sick role and receive medical attention. This condition, first formally recognized in psychiatric literature during the mid-20th century, continues to baffle healthcare professionals and researchers alike due to its complex underlying mechanisms and the sophisticated deception often employed by those affected. The manifestation of factitious disorder can take various forms, ranging from relatively simple fabrications of symptoms to elaborate self-inflicted injuries and tampered laboratory results. Patients may present with seemingly authentic medical complaints, complete with detailed histories and convincing physical presentations that initially appear legitimate to even experienced clinicians. Some individuals might inject themselves with insulin to induce hypoglycemia, consume substances to create gastrointestinal symptoms, or deliberately contaminate wound sites to prevent healing. The creativity and determination displayed in these deceptive behaviors often astound medical professionals, who may spend considerable time and resources pursuing unnecessary diagnostic procedures and treatments. The psychological underpinnings of factitious disorder are deeply rooted in complex emotional and developmental factors. Many individuals with this condition have histories of childhood trauma, neglect, or abuse, which may have taught them that illness or vulnerability was the primary means of receiving care and attention. The medical environment provides a structured setting where they can experience nurturing relationships with healthcare providers, albeit based on deception. For these individuals, the hospital becomes a sanctuary where they feel valued and cared for, even if this care is obtained through fraudulent means. The attention received from medical staff, the concern of family members, and the sympathy of others fulfill a profound emotional need that they struggle to meet through conventional relationships. Healthcare systems worldwide grapple with the significant challenges posed by factitious disorder, both in terms of diagnosis and management. The condition places enormous strain on medical resources, as patients often undergo extensive and expensive diagnostic workups, unnecessary procedures, and prolonged hospitalizations. Emergency departments and specialized units may unknowingly become revolving doors for these individuals, who may present repeatedly with various complaints or seek care at multiple facilities to avoid detection. The financial burden extends beyond direct medical costs to include lost productivity of healthcare workers, delayed care for genuinely ill patients, and the psychological toll on medical staff who discover they have been deceived. The diagnostic process for factitious disorder requires exceptional clinical acumen and often involves a multidisciplinary approach. Healthcare providers must maintain a delicate balance between healthy skepticism and compassionate care, as premature accusations can damage the therapeutic relationship and potentially harm patients with legitimate medical conditions. The diagnosis typically emerges through careful observation of inconsistencies in the patient's history, unusual patterns in their symptoms, or direct evidence of deceptive behavior. Video surveillance, while ethically complex, has sometimes been employed in hospital settings to document self-inflicted harm or tampering with medical equipment. Treatment of factitious disorder presents unique challenges that require specialized psychiatric intervention and careful coordination among healthcare team members. Traditional therapeutic approaches must be adapted to address the underlying psychological needs while confronting the deceptive behaviors. Cognitive behavioral therapy has shown promise in helping patients recognize and modify their behavior patterns, while psychodynamic therapy can address the deeper emotional issues that drive the need to assume the sick role. However, many individuals with factitious disorder are resistant to psychiatric treatment, particularly when it threatens their ability to continue receiving medical attention through deceptive means. The phenomenon extends beyond individual cases to include factitious disorder imposed on another, previously known as Munchausen syndrome by proxy. In these situations, a caregiver, typically a parent, deliberately produces or feigns symptoms in a dependent person, usually a child, to gain attention and sympathy. This variant of the disorder raises serious ethical and legal concerns, as it involves the abuse of vulnerable individuals who cannot protect themselves. Child protective services and legal systems must often intervene to safeguard victims while ensuring that caregivers receive appropriate psychiatric treatment. The advent of digital technology and social media has created new avenues for factitious disorder to manifest, with some individuals fabricating illnesses online to gain attention and support from virtual communities. These digital deceptions can be particularly harmful as they may influence others to question legitimate medical conditions or discourage people from seeking appropriate healthcare. The anonymity and reach of the internet can amplify the impact of these deceptions, creating widespread misinformation about medical conditions and treatments. Prevention and early intervention strategies for factitious disorder focus on addressing risk factors and improving healthcare system responses. Training programs for medical professionals emphasize the importance of recognizing potential warning signs while maintaining empathetic patient care. Developing better communication systems between healthcare facilities can help identify patients who may be seeking care at multiple locations for fabricated conditions. Additionally, addressing societal factors that contribute to the development of factitious disorder, such as childhood trauma and neglect, may help reduce the incidence of this condition. Research into factitious disorder continues to evolve, with scientists exploring neurobiological factors, genetic predispositions, and environmental influences that may contribute to its development. Advanced neuroimaging techniques have revealed brain abnormalities in some individuals with the condition, suggesting possible biological underpinnings. Understanding these mechanisms may lead to more effective treatments and better outcomes for affected individuals. The stigma surrounding factitious disorder often complicates both diagnosis and treatment, as healthcare providers may feel frustrated or angry when they discover deception. However, it is crucial to recognize that individuals with this condition are suffering from a genuine psychiatric disorder that requires compassionate, professional intervention. The challenge lies in providing appropriate medical care while addressing the underlying psychological needs that drive the deceptive behavior, ultimately helping patients develop healthier ways of seeking attention and forming relationships with others in their lives.